sir.
It's a dual plating.
Yes, sir. Dual.
We tell like that. It's a dual plating. I'm used to two approaches. One on the
Lat
posterior side and one on the lateral.
lateral side.
Two approach you have done, only one approach.
Two approaches, sir.
Two inch? Incision. Still
The
the
lateral.
angle, if you see this now, angle is come still valgus. More than 8, 9, 10 degrees this is. If you see normal angle should be about 6 to 7 degrees of valgus,
Yes,
right?
yes.
Now if you see this, it's more than that. If you draw a line, it comes here, it goes here like this. Valgus is still there,
Yes.
right?
25 years old male, sir, with 10 days old grade 2 compound fracture neck of third metatarsal of left foot. 10 days before, he had a history of roll-over of bike over his left foot. Then he underwent primary treatment with a local doctor where sutures were applied. 10 days later, he came to us for suture removal and serious discharge. So we did wound debridement, and we also fixed the metatarsal neck fracture with a K-wire and a
Why?
below knee slab.
He has come with infection, no? Still you want to put K-wire here?
There was just only serious discharge, sir.
Also, you think it definitely infected, right? So why do you want to put one more thing here? Just immobilize in below knee cast, that's enough. Because it's a ROGC case you want to put. Maybe, do you think it's necessary to put here? You can as well put a immobilize and then you finish off. Already it's infected, looks infected. Kada? Right?
Both wound photos don't make any sense. The first one has silk sutures. So you will
Maybe-
obviously open it, debride. What is the extensor tendon status? That we need to know. Is the bone exposed? Third metatarsal head. What?
What?
There's no fun in putting a K-wire.
Was it tidy or untidy wound? That also should be there.
It was
But last week we discussed, put representative, whatever you want to show. That image has to be there.
Okay, there is no need to put that.
there.
అంతేనా ఎందుకు ఇవి క్లియర్ మచ్చా ఇవి క్లియర్ చేయడం లేకుండా ఈ తర్వాత చేస్తులే డిస్కషన్ యూ వాంట్ డిస్కస్ నౌ
Yes.
తర్వాత ఓన్లీ ఎక్సర్సైజ్ యూ డూ ఇట్ నౌ దెన్ విల్ ఏం కేసు ఇది
Sir,
ఇదేంది
15 years old boy.
అచ్చా రైట్
Antibiotic
10 months, sir.
impregnated cement పెట్టాం.
ఓకే లేటర్ ఆన్ కెన్ డిస్కస్ ఉండదు
Good morning, sir.
నీట్ కూడా సరే దాంట్లో తొందర అయిపోతుంది
The 77-year-old female with 10 days old intracapsular fracture of left femur, sir. We have done hemiarthroplasty for left hip, AMP, sir. Austin-Moore process.
అయ్యి ఫస్ట్
This
ఎక్స్రే ఫస్ట్ ఎక్స్రే ఇది ఇంపాక్టెడ్
No, sir.
displaced no is displaced or impacted one
Subcapital type, sir.
how much is angle Powell's angle ठीक है right
40 degrees.
right
47-year-old male with close comminuted both bone middle third shaft fracture of left leg, sir. We have done CRIF with ILN for left tibia. 45-year-old male close proximal third middle third junction shaft fracture of right femur. Winquist and Hansen classification type 3. We have done CRIF with ILN for right femur.
how is this the writing here
Yes.
in one you can't see this no is it well reduced or not
No, sir. In lateral view, reduction is
Hmm.
incomplete.
Anyway, it will right. See this? Polio. Polio na. Yes, do it, sir. Show the first X-ray. Was it a normal limb or a polio limb?
Polio limbs.
How to make it polio limb? How to make out it is polio limb? Patient is not there, just X-rays are seen here. Can you make out it is a polio limb?
Soft tissue is thin, sir.
After what bone? Bone is thick.
Bone also thin. Osteoporotic bone.
See, the cortex is a very good still. If it is a polio limb, no, the complete penciling of cortex will be there. Widening of the medullary cavity will be there. Then you can call it a polio limb. Something else it is there, I don't know. You have seen clinically,
Yes, sir.
patient has some deformity.
Shortening.
Polio, how did it is a polio limb? Is it a flexion, abduction, external Now what the deformity has?
He is able to walk, sir. But
Now then, hand to knee gait is there. But how did you say it's polio limb? That's what I meant to say. Clinical picture is not there.
yeah, history 6 months. When he was 6
But-
months.
You have seen the patient, no?
Yes.
So how is the patient? Is he walking?
Walking, sir.
Walking is not.
Without
to-
support.
Hand to knee? No.
No, sir.
Able to walk?
Without support, sir.
Why is he walking?
No, sir.
Well then, is it polio now? The flare limb or a polio? What is this? It's not a flare limb.
No, sir.
No, then what? Muscles around the thigh are acting? But,
Yes, sir.
But you said it's a polio limb. But I want to know what polio limb is there or not.
Thin limb, sir. Leg is shortened.
Something else it could be there. See, if it's a polio limb, definitely this much cortex is not there at all. Thinning or penciling of cortex will be there, widening of all this will be there. Any other thing should be there, I don't know, but I have not seen. Patient photograph is there, can you show?
No, sir.
Okay.
So this is a 50-year-old female with a 1-week-old intercapsular fracture of right femur, sir. This is subcapital type of fracture. We had an hemiarthroplasty with a 37 mm AMP, sir.
What's the age?
50 years, sir.
50 years you want to do AMP now?
But she looks more than 50 years of age, sir.
No, you said 50 years.
Yes,
Are you
sir.
justified in doing this?
Arageshi has given him 50, sir, but she looks more than that age. This is a
Ev-
subcapital fracture, sir.
Hey, where is subcapital here? It's cervical only. It's subcapital.
It looks like it's
So
a
this is, huh?
it's a subcapital.
So this is cervical only, no? If somewhere here it is subcapital, but now this is the length you are having here. Yeah. But 50 years, suppose whatever it is now, you want to fix it or you want to
Usually
replace
in
it?
50 years we will go with the osteosynthesis, sir.
So what do you do for this?
We have done hemia, sir.
No. Osteosynthesis, what do you do? You want to do anything?
We can go with inverted CC screws
Or DHS?
or DHS, sir. Yes.
Yeah. Why was, bipolar not done for this?
She is not a actively demanding patient, sir. So we can go with.
See, young people you always choose for a bipolar, not for the AMP, no?
Yes, sir. She is not physically demanding patient, sir. So we
Not
can
demanding. The hip, how the hip is normal. Or arthritis is there, something wrong, you can do bipolar.
Okay, sir.
But young people always choose only the bipolar only.
Okay, sir. Sir.
Yes. That's the reason it was there. That was. Length ekkuntana. This is not sitting inside one. This is what. ఎవరన్నా చేసి నువ్వు చేసినావా?
Sir, I was there, sir.
Huh?
I was there for the case.
Who has done it?
Lakshmikant, sir.
లక్ష్మణ్ నువ్వునా? మరి అక్కడ కిందికి రాలే? వై యు నాట్ సిటింగ్ ఇన్ సైడ్?
Easy గా వచ్చేసింది.
ఉందుగా it looks all lengthening also if you here. Lengthen అయిపోయింది. But why to choose, I mean, bipolar దీనికి? Lakshmikant, bipolar is easy, no, for this. Why AMP for this? Old people I can say AMP is good, but now young fellow, let him have this chance of getting one more. But still it looks, young fellow always choose only that, sir, bipolar.
Yes, sir. This is a 24-year-old male, sir, with a 2 weeks old distal and radius fracture of left wrist. He has a trauma of skid and fall from the bike, and he has also LOC, and he says he doesn't remember the mode of injury, but probably mostly due to fall on outstretched hand with a palmar flexed wrist. You can see the distal and corticocancellous fracture. Radial height is lost, and radial inclination is also lost here.
What deformity he has?
Sir?
What deformity will have this? With fracture, what deformity you get?
Palmar tuning fork.
Tuning fork.
I mean table. Sorry, sir.
Very good.
Table.
What that
Sorry,
is
sir.
tuning fork.
That is
This work?
spade.
Huh?
Spade. Garden spade deformity.
ఈ అడుగు చూసి చెప్పాలా ఇది తెలియదు.
I just forgot that name. This is Smith fracture, sir. You had an ORF with a 4-hole L split.
Plate where? Volar or dorsal?
On the volar side, sir. Volar side. Modified hand. We have gone through modified Henry's approach, and we have done 4-hole L split.
What approach?
Modified Henry's. Modified Henry's.
Means what?
We will give incision between FCR and brachioradialis.
Normal approach is what? Henry's approach?
Between brachioradialis and brachial artery. I mean radial artery. Sorry, radial arteries.
Right.
No, sir. We
Left
didn't apply any distal screws. The reduction was stable, sir.
Actually looks oblique still. Right. There is a chance to put screw also. Distal fragment is really nice, no? You could have put one screw here. No.
We tried, sir, but it was not stable with a screw. No, screw was loose, sir. Thanks.
Morning, sir. These are the X-rays in Unit 2. 41 years old male, closed tibial plateau fracture of right tibia. Lateral corner involved, posterior laterally involved. In lateral view, posterior segment is there. Few 2 years back, sir. These are the CT film. Dynamization. Yes, sir. FRCS type 2, sir, and in CT we should confirm column. Only lateral condylation. Depression. These are the CT fillings. CT for any posterior segment is there. The posterior lateral segment is there. We have done LCP plating for right tibias. Yes, sir. No DNVs.
Good morning, sir. 20 year male, sir. 2 weeks old, close, fifth metacarpal fracture of right hand, sir. We have done open reduction, internal fixation with K-wire fixation.
Can you improve the positioning? Any percentage?
No, sir.
15% of improvement?
No, sir.
Now we are going to produce non-union. Most likely.
What fracture is that? Is it oblique fracture or capsular fracture?
Obliques.
What is the need to put KR for this? Suppose I put a gutter screen and then you
Sir, patient wants surgery, sir.
So that is the indication. Never tell that.
want surgery, no.
Patient is having the JC.
No, sir.
We conceive after contact.
So suppose you are working somewhere in a village, why you want to put KR?
No, sir. First, conservative. Gutter slabs. Gutter slab.
Gutter screen can be applied nicely to this action here. So why do you want to put a KR for this?
And if at all it is done, it should be an anti-grain KY, not retrograde. Not from distal to proximal.
Yes, sir.
Retrograde is different. Okay. So if you make a small hole at the base of the fifth metacarpal and take a KY 2.5 mm, try to cut the KY to the length that you require, and then bend it with a small bend of 90 degrees, so that this bent portion of the KY will tend to push the subchondral bone in the head of the metacarpal, tries to maintain the length of the metacarpal. It is here the maintenance of the length that is important for reduction. So if you push the guide wire, KY up to the subchondral bone, it tends to reduce the fractures. Now, when you put it from distal to proximal, it is tending to not tending to correct the angulation, the rotation. How are you sure that you have put it in proper rotation or not?
Yeah, then open or close?
Sir, open.
You open it. It will get anti-grade.
Laterally open and
First,
from distal
You
to
pass the KY from distal to proximal.
retrogrades. Distal to proximal.
Retrograde meaning is different. Retrograde is open the fracture site, put the KY in one fragment, drive it out, and then reduce the fracture and put it downward. That is called retrograde nailing or wiring.
Anti-grade is from above, here. Legs the MP joint, from here it comes directly to that's what anti-grade.
Or from the base to the head is ideal. Because the blunt bent portion of the KY will tend to reduce the fracture by pushing it and aligning.
No normal fracture.
Close, close.
How do you judge the rotation here? It must have been put in mal rotation. Put the post up.
What on that?
How do you know it is not mal rotated? If you put the finger on the metacarpal flexion when you are driving it, okay, if the fifth finger is parallel with the ring finger, that means there is no mal rotation. Otherwise, if you keep it single
Okay.
finger, fifth finger flexion, and then put the wire from distal to proximal, you don't know whether it's a mal rotated or normal rotation. always keep the adjacent finger so that it acts as a guide for correct rotation. And at least after putting the KY, you have to flex the finger and see whether they are parallel or not. Otherwise, if it remains in small position, small rotation, it crosses over the other finger either this way or this way. That is a very important precaution.
Yes. Percutaneous.
Percutaneous. But open the fracture.
Open it fracture sides.
Probably got more rotational deformity there or not?
It's there.
Not dead.
No. Yeah, see, that doesn't look like it's reduced. Yeah, go on. Probably. Just start. General club is finished? No. No. Okay.
Good morning, sir. Today's my journal is regarding optimizing indications and techniques in osteotomy around knee. This is a review article I've taken from European National Association of Orthopedics and Traumatology, published in 2022. The main objectives are to analyze the coronal plane deformities and to plan further correction. The most common deformities seen around the knee are genu, valgum, varum, recurvatum, and tibia vara, and these are the most common causes. Before planning for type of osteotomy to be performed, we need to assess certain radiological parameters. First is mechanical axis. It is a line drawn from center of femur head to center of ankle, passing through apex of intercondylar notch and tibial spines. Whereas anatomical axis is a line passing through diaphysis of both femur and tibia. Next is mechanical axis deviation. Normally, mechanical axis lies about 8 to 15 mm medial to center of knee joint. However, if the mechanical axis deviation is more than 15 mm medially, it is known as varus malalignment, and if it is more than 10 mm laterally, it is valgus malalignment. There are 4 joint orientation lines for 3 joints. At femur, at hip, it extends from center of head to tip of greater trochanter. And at the level of knee joint, it is the level of distal femoral condyles and proximal tibia. And at the ankle, it is the level of tibial plafond. Normally, the basic principle is, in case of normal joint orientation, all the 4 lines are supposed to be parallel to the ground on weight bearing. And there are 4 joint orientation lines, 2 for femur and 2 for tibia. But regarding osteotomy of knee, 2 angles are considered important. Lateral distal femur and a medial proximal tibial. Lateral distal femur is angle between mechanical axis of femur and joint orientation line of distal femur, which is about 88 plus or minus 4. And medial proximal tibial is angle between mechanical axis of tibia and joint orientation of proximal tibia, which ranges from 87 plus or minus 4. More or less, all the 4 angles are near 90. Based on these angles, we can identify the source of deformity, whether it is in femur or tibia. So in this X-ray, you can see the mechanical axis is deviated laterally, hence it is a valgus deformity, and joint orientation line of tibia is almost normal, whereas that of a femur has been reduced, so the source of deformity is in femur. Next, here the mechanical axis is deviated medially, so it is a varus deformity, and the joint orientation line of tibia has been decreased, where that of a femur is near normal, hence the deformity is in tibia. Types of osteotomies performed around knee are high tibial osteotomy, distal femur osteotomy, double level osteotomy, slope changing, and anterior tibiotubercle osteotomy. Proximal tibial osteotomy is most common procedure done in case of unicompartmental osteoarthritis of the knee. And the basic principle is,
That's why to explain again how to locate the deformity, whether femur or tibia
Clinically.
or both. Later on.
clinically,
No, go on.
Okay.
Later on.
The basic principle of high tibial osteotomy is, in order to unload the stress over one compartment, we correct the malalignment by changing the mechanical axis, therefore redistributing the stress on the knee joint. And it can be of medial open wedge, lateral closed wedge, dome osteotomy, or medial open wedge hemicalotasis. Criteria for selection of patients are: age should be less than 65, moderately active with isolated medial compartment osteoarthritis, and varus malalignment should be less than 15, a minimum range of movements of more than 90 degrees flexion, non-smoker, non-ligamental balance, and BMI less than 30. Whereas contraindications are age greater than 65, severe grade of osteoarthritis, ROM less than 90 degrees flexion, greater than 15 degrees flexion contracture, or if more than 20 degrees of correction is required, and in case of inflammatory arthritis. Yes.
So, chronic PCL insufficiency, we do which to correct the.
Next is assessment of degree of correction. Normally, in order to unload the stress over the medial compartment, the posterior mechanical axis should pass through a point known as Fujisawa point, which is about 62.5% across the tibial plateau if measured from the medial side. So, correction angle is angle formed by line drawn from this point to center of femur head, and other line drawn from the point to center of ankle. These two lines where they intersect and form this angle, this is the correction angle. Amount of wedge to be resected is, for every 1 degree of correction, about 0.8 to 1 mm of length of wedge has to be resected, or we can use the formula diameter of tibia into 0.02 into correction angle.
You can resect it, or you can open wedge.
Open it.
Open, so many ways. Nowadays, most commonly done is
Open
wedge osteotomy. Because what's the disadvantage of a closed wedge?
Shortening.
You make limb
Shortened. Medial open wedge osteotomy. Here a single osteotomy line is drawn to a point 3.5 centimeters inferior to a joint line towards the head of fibula without breaking the lateral cortex. Then progressive opening is done till the desired amount of correction angle is achieved, and then fixed with a plate and filled with the bone graft. Advantages are accurate correction of deformity can be achieved. We can avoid injury to perineal nerve damage, preservation of proximal tibial bone stock, and easier conversion to total knee replacement, and there is no leg shortening. Whereas disadvantages are, it requires bone grafting, there is increased risk of delayed union, non-union, changes in tibial slope and patellar height, and prolonged non-weight bearing may be required. Lateral closed wedge osteotomy. Here the proximal osteotomy line is drawn parallel to articular surface 2 centimeters inferior to joint line, and distal osteotomy line is determined based on correction angle, and the bone wedge in between them is removed and fixed with a plate. This procedure often requires some tibiofibular joint disruption or fibular osteotomy to allow correction to take place after removal of wedge. The advantages are faster healing, no bone graft is required, and early mobilization can be allowed, whereas disadvantages are disruption of proximal tibiofibular joint anatomy, reduced proximal tibial bone stock, and difficulty to precisely adjust the deformity, increased risk of peroneal and popliteal artery injury, and there will be shortening of leg. Proximal tibia to buccal.
Paper is very outdated. It's around 2000s, but now the high tibial osteotomies that we are doing are all biplanar osteotomies. So that has to be stressed.
Distal femur osteotomy. It is used to correct the severe valgus deformity that might be due to post-trauma or due to growth disorders, done in case of young active patients with lateral compartment arthrosis. So the indications are age less than 65 with isolated lateral compartment osteoarthritis, minimum ROM of 0 to 120 degrees, and a normal BMI. Whereas they are contraindicated if there is severe lateral compartment osteoarthritis, associated medial compartment or tricompartmental osteoarthritis, any inflammatory arthritis, osteoporosis, or if the deformity is more than 20 degrees. Distal femur osteotomy can be performed as a lateral open wedge technique or as a medial closed wedge one. Lateral open wedge technique is more demanding. There is increased risk of delayed union, non-union. There is increased risk of hinge fracture and more complications in hardware. Whereas medial closed wedge osteotomy has a faster healing and low instance of non-union.
So now things have changed because of the technology. All whatever you mentioned, doesn't they should know the basics.
Next is double level osteotomy. It is indicated when there is severe varus deformity, so that correction at one level would create a deviation of a joint line, or in preoperative planning, if the medial proximal tibial or lateral distal femoral angles are more than 90 degrees, or if the planned bone wedge is more than 15 mm, then double level osteotomy is to be performed. Next, this is slope changing osteotomies, which is anterior closed or anterior open wedge osteotomy. The normal tibial slope being 5 to 15 degrees. If the slope increases by more than 15, it causes anterior translation of tibia on weight bearing, which further increases stress on the native or ACL graft. Whereas decreased slope less than 6 degrees causes posterior tibial translation, leading to increased stress on a PCL or PCL graft. Hence, in cases with recurrent ACL reconstruction failures associated with slope more than 12 degrees, anterior closed wedge osteotomy can be done. And cases with recurrent PCL deficiency with posterior tibial slope less than 6 degrees, we can go for anterior open wedge osteotomy. Next is anterior tibial tubercle osteotomy, where the tibial tubercle is osteotomized and pulled medially in order to improve the angle of pull in patella. It is done in cases of recurrent patella dislocation and patella instability. These are the cases done in our hospital, sir. 17 years old female with unilateral genovalgum deformity of right knee. Here we have done medial closed wedge osteotomy, sir. These are intraoptics.
Can you just detailedly explain here, this is a case example from the hospital. So you can again explain what are the angles, where is the deformity, what you have done, why you have chosen a medial closed wedge osteotomy. Can be little detailed, then everybody will understand why we have done this procedure.
Only one side was done, sir.
You were not there. You know anything about the case? Try to explain. Did those lines were drawn by you, somebody else?
No, it was already there.
Already
Mechanical
there.
axis. Sir.
Can you interpret? I know difficult. Can you interpret? Where is the
This
deformity?
Sir, as we have discussed, if we draw the joint orientation lines here and mechanical axis of femur, we can see the joint orientation line of femur has been reduced, sir, whereas that of tibia is almost 90. Hence,
So
we
the
have seen that
deformity
is in
is
femur.
Okay. So what was the etiology? It's cause of this one? Traumatic, developmental, or what? You don't know.
Development, not traumatic, sir. Yes, sir.
So you think it's a developmental? Or rickets? Don't know. Okay.
This
Deformity is probably may not be in the knee joint, not in the knee joint, but not close to it. It's extra-articular.
You isolate the distal end of the femur and the tibia. They look normal. Their alignment is normal.
So the pathology is not inside the joint. The valgus deformity, the common valgus deformity is what is the cause?
rickets.
Anatomically. Distally
Distally.
what? Is a hypoplastic? Medial lateral?
Lateral, sir.
Lateral. So common cause would be hypoplastic.
Lateral femoral condyle.
It doesn't look like it's hypoplastic here, is it?
Coxavara is
Hips maybe off. Coverage. Because of this deformity.
there will be compensatory Coxavara.
But significant deformity. You don't see this kind of
There is a
deformity.
lot of deformity in the left femur also.
Femur, yes. As it was
Bovine,
yeah.
lateral.
Mainly from the apex of the deformity is there. Here also there is a deformity.
Sometimes they develop ridge side deformity.
This is another case, sir, where 42 years old female present with bilateral knee pain, left greater than right since 8 months. This is hip knee angle, sir. Normally they are about 1 to 3.5 degrees varus. Here it is 8 degrees varus and 4 degrees of varus. Here we have done
Phones are silent, vibration, not silent.
Here, no, you have to mention which side we are doing, left or right.
We
Which
are
side?
doing only for left side, sir, where medial open wedge high tibial osteotomy was done. These are the intra-op pics, and intra-op this is to make sure we have gained the mechanical access.
Where is the Siam picture?
I did it.
Missed. So you put this one, then you check on the Siam. That's the easiest way. Whether you achieved the center of the hip. Okay? Where is the plate? You can't see plate there. Anybody?
Radiolucent.
Were you there for this case? Yeah. Yes?
It's a peak plate, it's polyethyrether ketone plate.
So it's a
Radiolucent plate.
And it's a open wedge.
Yes. Medial.
Sridhar was talking about this modern technology most of the time. This is a common way of doing high tibial osteotomy. It's very simple because the techniques, fixation has become very, common and popular. So you know, non-weight bearing, those things, putting in a plaster, not required. 6 weeks non-weight bearing, they join very well.
What advantage is plate? The advantage is there because of plate what you use.
Yeah, it is. See, what happens is, it's a contour plate, pre-contour plate, and if you want to use a graft, it's within this one there is a defined millimeters wedge is there, so you can put in between. Most of the time is right. Unless the big one, you don't have to. But this is the radiolucent, so that you know what exactly, how much you are. Doesn't interfere with your CR pictures, and the pre-contour.
How expensive it is, no?
Oh, very expensive. More than a joint. It costs more than 1.2 lakhs.
Not for the patient.
Not for the patient to see the plate without.
But see, you can use it. That's a technology.
Yeah.
We do not discuss about the cow. We can devise similar one. Take one of the plates and contour it. So we only derive the technology. Probably may ask one of the Indian companies to make it. They would be more than happy to make it. Cheaper cost. Yeah.
Conclusion, osteotomies represent a highly reliable and reproducing treatment option for knee pathologies. Appropriate patient selection and accurate planning are indicators for successful outcome.
Not there for other cases. We've done many cases.
What about pediatric cases? This other kind of.
We've done pediatric cases, many pediatric cases. Should have taken.
Last week there was a case discussion, right?
Yes.
Did you put plate for that or just costing is that? What I will costing you? What the correction that's in the
Epi5.
For your generation, that's okay, but for this people, I think they have to move on.
Okay, but children always fight only with the other.
Of course, young children, but I think probably the fixation devices are so advanced. So the whole idea of putting a plaster, stiffness, mobilization, so we can early mobilize and it's
Children is not a problem. Adults definitely do.
So, yeah. So I would like to bring three.
osteotomy not commonly done in children. Most of the time it's adults. If it is a femoral osteotomy, yes. Most of the time it's children or what is the genuvalgum is more common. Genuvalgum is very less common in India especially.
So the lot of attention with regards to high tibial osteotomies have been increasingly been appreciated because of the reason that it was previously thought so that high tibial osteotomies are little invasive or aggressive in terms of doing the surgery, but of late with arthroscopic surgeries picking the momentum, lot of cartilage restoration, root repairs, we have been seeing a lot of failure rate for the reason that if the varus malalignment is one of the key important factor for failure of all these fixations. So if a patient has got a cartilage defect, you are doing some kind of a cartilage restoration procedure like OATS or maybe some ACI, then you always have to check the malalignment, otherwise it will fail. Similarly, if you are doing a root repair or root reconstruction also, you always have to make sure that there is no varus malalignment. So ideally, a joint environment consists of cartilage, meniscus, ligaments, and the alignment. So alignment is a critical component to it, particularly with patients of around 45 years, 50 years. We have to be very, very careful with that. And second thing is regarding the Frank Noyes law, which I think you didn't mention. So 2:1. The posterior cortex is 2:1 on the front, because as we see, tibia is a triangular bone, and when you open, you know, you have always have to mention the slope also. In ACL deficient knee, you try to kind of increase the slope, or in ACL deficient knee, I think we can increase the slope, and PCL we decrease the slope to reduce the in chronic PCL insufficiencies. People now say that you don't have to do a PCL reconstruction, rather reduce the slope and leave it. So that is good enough. So, and again, advances part, I think a lot of computer navigation and PSA have come in place. So preoperatively we plan it, we understand how much of opening has to be done, and then you put a 3D jig and then do the cuts and then place the wedge.
And the plates advantage you are asking about that, because jigs are there to osteotomy, it's become very simple. And high-tibial osteotomy has come back in a big way. Probably we are not doing as many, but in Europe and America, instead of doing unis, they're doing more. The malalignment is there, various alignment, and the patients' results are good. Yeah, you don't have to. And open is simple. Open wedge osteotomy is very simple, because you don't have to match anything. Close it, very precision. Close to wedge means again you have to. Open wedge is most of the time not single. This is not a single plane. This is done in two planes. And going under the what is that patellar ligament, and it doesn't affect the extensor mechanism.
If you're correcting wedge of more than 10 or above, may say 12, you should go double level.
Yes.
Double level.
Is it only for unicompartmental or
Unicompartment.
Now they say that UK is not, it's almost like a failed surgery, so they're more on the osteotomies.
Unicompartment.
And alignment jig is there, can you see there? So you check on the C-arm, should be two rods are there, one on the hip, and you can open the wedge and see how much. You don't have to measure previously. Of course, you have to have an idea, but you can directly see under C-arm and how much correction. You open it up till center is in the straight line. That's the jig.
You have the images on WhatsApp. You can open them. You have the image showed.
So hinge fractures are the common complications of HTOs. So to avoid that, we place a hinge pin and also release MCL sufficiently so that you can open the wedge comfortably.
We should have, I think probably next year, the pins, alignment, the direction. No, that's why the directional osteotomy in such a way that it will not disturb the patellar ligament attachments. But the jigs are there. So design jigs, so we just have to, probably end of the lecture we can get into this. So you can see clearly on the C-arm and gently open it up, and for opening also you have the wedges, how much to open. Put wedge inside, metallic wedges, then fix it. And it is very stable osteotomy. The big thing is we don't cut this side, very stable, and it unites. It is an adult, it unites in 6 weeks. And after 6 weeks you can start the weight bearing.
That converting a HTO to a total knee is far difficult compared to UK to TK, but of late data compares both showing the same. So if you convert a UK versus H2, it's both the same. If you want to do a TK.
And the alignment is not changed much. Rather, it helps in doing the joint replacement. So osteotomies around the knee is very popular topic for orthopedics. Your career-wise or an examination, always there is repetition of this question. Osteotomies around the hip joint and the knee joint. So everybody should be familiar in these osteotomies. Indicate their indications, basic principle, and procedure technique. Maybe. What is it? As Ravi said, if deformity is not significant, up to 12 degrees, you can correct at the joint level. We are almost correcting at the joint level here, isn't it? It's not outside the joint because within the patellar ligament. More than that, we have to do extra outside the tubal ligament, tubercular attachment. Okay, good. But you should have. I was talking about there was an article in COR. This effort is very COR. You didn't find an article in that one?
There were articles.
Clinical orthopedics.
There is a specific articles on each osteotomy. This was because for the PGs to understand.
Yeah, that's good. Basic one, and it's not very advanced also. If you present them with the latest one, then you get confused. So they should know the basic one also. Very good. We should have shown more cases. We've done so many osteotomies. We have recently, not recently, we have done quite a few osteotomies. Probably we can do here unicondylar. Not unicondylar, unicompartmental knee with various deformity. Do arthroscopy first, then do osteotomy. Similar technique, but plate can be used on T-button still can be used. Contour plate.
Sir, good morning, sir.
You wanted to?
Sir, I need 5 minutes to. I need 5 minutes to download.
Put it in the download and let me know.
Oh, one second.
Okay.
The case discussion first, sir. The 15-year male with a grade 1 compound middle third shaft fracture of left femur, sir. 10 months back, we done open reduction and plating for left femur. After 6 months, he came with discharge sinus and the X-ray showing non-union.
See this one, but if you see an X-ray like this
Yes.
in a child, so you should suspect
Osteomyelitis.
infection.
Yes, infection. No.
How old is the patient?
15 years, sir.
What was the reason for plating? Who did this?
Jairam, sir. Not open, sir.
You have done it. 15. No?
Yes.
Okay, next one. Next level. So what's the plan?
We are
Organism, what was the organism?
Serratio Marcis.
Is it a good one or a bad one?
Marcisans. Marcis.
Is it gram positive, gram negative?
Gram negative.
Serratia.
Gram negative.
Comes from where? Is there fecal infection? No. Serratia comes from gut infection.
Yes.
Don't answer. It's sensitive to
All
gentamicin means
Yes.
probably gram negative.
gram negative.
Gram negative.
So we have done implant removal and bone cement, antibiotic coated bone cement, sir. 6 months back.
Okay.
With gentamicin impregnated. This is after 1 month after bone cement impregnation, sir.
Doesn't look like there was a union. No, next one. There is one thing line.
It's not united.
Not united.
Yes, sir. Not united.
Only
Was he walking?
No.
with walker.
With walkers, sir.
Okay.
After 3 months, bone cement impregnation, sir.
Skin condition again.
Infection is controlled, sir. No sinus and discharge.
Fracture also united.
Yes. Mm.
X-ray quality is not good. Probably it is that light. And there is superimposition of bone cement. Medial bridging appears to be good.
Probably callus seems to be
Improved. How did you protect the lip after surgery?
So no,
It needed protection.
for 1 month we kept slabs, sir. That's
Slab is not going to help. At least Thomas did. Slab extends only up to the fracture site. If you put it up to the gluteal fold, it only supports hardly any proximal fracture.
this
it's not.
cement.
Yes, sir. Cement. This cement.
So what happens cement after few weeks?
It's,
Once antibiotic is released, it becomes a dead material.
Yes.
Okay?
Removed.
Source of you have to remove. You can't keep more than maybe 6 weeks, 2 months. You have to take. So what's the plan now?
We plan to remove the bone cement, the cement, sir. Then nailing, nailing and bone grafting. The plan.
ESR CRP?
No, it's normal, sir.
Normal.
Normal, sir. No, sir.
So probably it was sensitive to most of the organisms.
Or an X6 would have given some better stability.
Okay, if it is clean, then we can do.
Yeah.
Next.
23 years old male, sir. 9 months ago, he came with the middle third shaft fracture of right femur. We fixed with ILN, sir. Close reduction internal fixation with ILN. This is the immediate post-op X-ray. Then this is the 3 months post-op X-ray, sir. Callus was seen. Then he came again at 7 months post-op X-ray, where we found that the distal screw was broken, and this is the present and advice for dynamization, sir. Since even after 7 months, it has not united.
Already dynamite. One screw. Is it a good thing or bad thing? Broken.
Good.
I'm getting compressed.
This is the present X-ray, sir.
So
Right how
dynamite, which screw you want to take? This one or top one? Bottom or top?
top one static has
Want
to
to take top one or bottom one? Which one will not affect the stability? Proximal screw, distal screw, instead of fracture.
prox.
Say loudly.
Not confident.
Isthmus, where is the isthmus? Proximal to the fracture, distal to the fracture. Isthmus is there. So if you take these ones out, what happens? It will
They'll
become
be unstable.
Why do you think this screw is broken than that one?
Stress rise.
Why this screw is broken? Why not proximal? Biomechanics.
Stress rise.
So more stress on this one. So there is a mobility, more mobility here. No mobility there. Probably you should replace this screw, take the screw out. Understood? You should put back this screw, take it out and put a new one, and take the screws out.
Okay.
It gives stability as well as comfort.
Okay.
Ideal time for the dynamization is around
3,
6 to 8
6.
weeks. There is no callus. Then that is the best time. After 7 months, already irreversible changes might have taken place. Dynamization may not work effectively.
Sir, or
Dynamization is essential.
Because the healing process might have come to halt.
can we
Can't hear me, Muscle.
Can we redo nailing with bone graft?
Redo nailing, yes, you can do it.
with bone?
But size is good, length is good.
And without disturbing the nail, you can open the fracture site, put a neutralization plate, a small plate, and then put bone graft. You don't need to redo the entire nail because nail appears quite good.
But the screw should be replaced. Mistake is they leave it because there is no stability. And they just make
Rotation plate and bone grafting probably will be successful without redo nail.
big communicated piece.
BMAC.
Bone graft is ideal. It's already long standing.
9 months.
We have to open the fracture site anyway. See.
Clear the fibrous tissue.
Okay.
Thanks.
Thank you, sir.
BMAC also is an option.
BMAX also bone graft. It is also bone graft. Taking liquid bone graft instead of solid bone graft.
Minimally invasive.
Answer.
Any more X-rays?
No, sir's video.
Okay.
Okay.
And then once you have it there, then take the stripper, so it's one of the important point is to make sure that we are directing it to the head of the fibula, making sure that we are approaching the right path, and also not avoiding avoiding the common peroneal injury. So we kind of here make sure that we are clearing all the adhesions to the tendon. Yes, so contraindications for harvesting, particularly peroneus longus, is flat foot and chronic ligament insufficiency around 9. No, in flat foot should not do it because sir. But it is.
So that's what we are doing a tenodesis here, sir. So with the brevis that moves also your flat. Yes, so that we are not disturbing.
So you are attaching the rest of the distal part of the longest brevis.
So the tension is maintained, the arch is not collapsed. That's why the tenodesis part. Yes. We are removing the distal part is still intact, sir. Whichever goes to the first
So
metatarsal.
So the reason I wanted to show is because more and more now people started adopting towards peroneus longus tendons as well, because sometimes graft hamstrings can be so thin and maybe sometimes it can be attenuated, so we should always be prepared to have a graft ready for
Especially
the-
revisions.
yes, sir.
Revisions
Especially
also
for
very
revisions.
useful because, and of course there is a lot of debate about taking hamstrings. It will, the hamstring is ACL friendly muscles. Hamstring should be strong to support ACL. So
Yes, sir.
that's why.
Especially with females where we get very thin hamstring tendons. So this can be a add-on graft.
How do you identify brevis and the longest? Shishma? How do you identify brevis and longest? Is here?
Yeah, she's there.
When you open lateral malleus posterior aspect, they show that. How do you identify? Which one is front, which one is anterior, which one posterior? Longest is anterior? Longest is anterior. You misled. Brevis is brave, so it is in the front. Remember that. Brevis is anterior to the longest.
And you can see the muzzle belly also for the brevis. So
Okay, that's good.
yeah.
Another take-home point in the medial meniscus is any flipped or bucket handle tears have to be fixed very robustly. So that's why we have taken those two traction stitches, reduced the meniscus back, eliminated any chance of that getting again flipped back into the notch, and put all your suture devices serially so that you get a good robust fixation.
Also, at least now we have got fast fix flex wherein you can bend your all inside device, but previously those devices are pretty much only straight, so you cannot really approach the body from the portal. So
Probably we can get the needles here. We can.
yes, sir. With we have the normal
Now
needles.
there's a technique to use with the spinal needle also, sir. Or these gem shading needles are there, which are more rigid. We can use that also as a inside-out technique. As a
Very
published
cheap.
paper.
See, what happened, most of these menisci are weak compared to normal one, especially chronic. And all inside technique, what happens, it goes through the meniscus, it damages, and it may not hold, they'll cut through. So better, if it comes through the capsule and
Tools
pulling
are just
back
putting
and
around the
around it.
meniscus is just full.
And most of the people, I think, the sports people, they do multiple sutures.
Yes, sir. Yes, sir.
Multiple
Up
sutures.
and down.